right. Well, I want to thank Dr. Korsnick, Dr. Ananthakrishnan, and Dr. Rabinowitz for really three outstanding lectures. We do have Dr. Ananthakrishnan and Dr. Rabinowitz with us for the Q&A session. Dr. Korsnick could not make it, unfortunately, but his questions can be answered by our two other experts very easily. So we will just jump right in now. Let me start, Ashwin, first with this question about, do you do a sigmoidoscopy or a full colonoscopy in patients with flares? And how important is it to test for CMV every time there is an acute flare?
So generally I do, it depends on their disease history, but generally for people with ulcerative colitis, studies have shown that a sigmoidoscopy is as good for assessing disease activity as a colonoscopy. And we certainly recognize that severe inflammation increases risk of perforation. So for the vast majority of these patients, I would do a sigmoidoscopy. I do test for CMV every time we do it because studies have shown that exposure to steroids can reactivate it. So even if someone had a sigmoidoscopy or a colonoscopy 4 weeks ago, they've been on 4 weeks of steroids since then, it's possible they have CMV now, complicating their disease when they didn't have it before. So I would generally repeat it for every colonoscopy.
If I can just add one other quick question to follow up to that. So when you test for CMV, is histology adequate, or do you do culture or PCR each time as well?
So that's a good point. Histology alone is not adequate. Histology alone has about a 40% diagnostic rate compared to either immunohistochemistry or culture or PCR. So it's important for you to know your practice setting to know which of these tests will be run by your lab and request something in addition to just your standard H&E stain.
Okay, great. Thank you. So Lauren, there's a question here about, does 5-ASA reduce preeclampsia risk just like low-dose aspirin does in IBD patients?
I think that's an interesting question. So far, we don't have any trials that have demonstrated that mesalamine monotherapy or otherwise impacts risk for preeclampsia. Although certainly its safety and efficacy in pregnancy is now well established. But this is really something that sort of the idea that a baby aspirin may be useful in patients with IBD planning pregnancy is sort of a newer concept. It's not something that we were sort of classically recommending to patients even as recently as 5 years ago. So it's always a little bit of a moving target. But I think helpful to understand that really the recommendation to start a baby aspirin is now sort of standard of care for most of us taking care of pregnant patients with IBD.
Okay. And then let me just follow up with another one here. So for the male population, is there any risk for sperm dysfunction, with JAK inhibitors? And would you avoid risankizumab in a female patient of childbearing age, given the lack of safety data in pregnancy?
Yeah, so this is two great questions. We don't have any human data on impact of JAK inhibitors on male fertility, although you could imagine theoretically JAK receptors are present in human sperm. So JAKs may be involved in sperm motility. That just isn't particularly well studied as yet. In terms of the second question, use of risankizumab in pregnancy, we don't have data yet. I will tell you that anecdotally, those of us who are seeing a higher volume of pregnant patients with IBD are frequently using it because patients are doing well. And we very well understand now that the risks of flare are probably worse to mother and baby than the risks of continuing a therapy that's actually working. The data that we do have comes from the open label extension from the phase 2 clinical trial. In that study, there were 3 pregnancies reported. The babies actually did relatively well. 2 out of the 3 babies did very well, and a third had complications that weren't felt to be due to the drug. So I think we're going to be seeing probably in the next short order, probably the next 2 to 3 years, that risankizumab is a reasonable option during pregnancy. And certainly, it's most closely related to ustekinumab, which is now relatively well accepted as a safe and efficacious drug in pregnancy and IBD.
Okay, great. Thank you. So Ashwin, if we turn to some other biologics questions, not in the pregnant population, is there any evidence for using risankizumab in fistulizing disease in Crohn's?
Yeah. So if you look at sort of the history of treating fistulizing disease, really the only drug that is approved for fistulizing disease would be infliximab. But we have post hoc data from a number of these agents where some people in the phase 3 trials had perianal disease. And we actually see very promising data for both risankizumab, which was in this question, and upadacitinib or Rinvoq. With both of these, among all the other agents that we have post-hoc data on from these trials, I think have shown the greatest promise for fistulizing Crohn's perianally. So those would be my three go-to options for perianal fistulizing disease, which would still be infliximab as sort of the strongest evidence, but certainly risankizumab and upadacitinib would be reasonably high up on the list in people who failed other options.
Okay, and then a quick question here is, are there any studies regarding using infliximab as induction and then switching to vedolizumab for maintenance?
There aren't, because there doesn't seem to be, at this point, a strong reason to do that. We recognize that all of these drugs are very safe. We also recognize that the biologics in particular are immunogenic, right? So you don't want to put somebody on infliximab and then stop infliximab and have to consider going back to it at some point in the future and risk antibody formation. That being said, with the availability of small molecules like JAK inhibitors, or to some degree S1P modulators, but primarily the JAK inhibitors, at this point, there's not a reason to think that episodic use is harmful for future drug efficacy because you don't form antibodies to it. So there is a lot of interest and use of JAK inhibitors episodically, like start somebody on a JAK inhibitor for 8 to 12 weeks, transition them to a biologic, which is safer from a pregnancy standpoint, and then you will not be sort of burning your bridges in terms of future use of that JAK agent. So that I would do. I would not start somebody on a biologic only to transition to another biologic.
Okay, great. So this is kind of just a broader question that I'll just throw to both of you is, can you give any perspective or details about the longevity of maintenance treatment when someone is on an agent and when there's the possibility of stepping down therapy or stopping therapy when someone's been in remission for many years? I know that they're probably very specific situations, but in general, if you might have any comments about, when do you think it's okay and safe to stop?
I'm actually pretty interested to hear Ashwin's take on this. I think those of us who do this, particularly if we do it in big academic settings where we see really sick and complicated patients, our natural inclination is to say, if it ain't broke, don't fix it. If you've managed to get a patient into durable remission, fantastic. Leave them on the therapy that has allowed them to have an excellent quality of life with minimal, flares and or complications. But I think it also depends on the therapy that they're on, right? And so it comes back to this risk of immunogenicity. And for certain biologics anyway, if patients are really insistent on de-escalating or even stopping therapy and they're on an agent that has a lower risk of immunogenicity, where theoretically, if they were to flare again, you could restart that drug with less risk. It's a different conversation than somebody who had, for example, complicated acute severe ulcerative colitis. We managed to turn things around and get them on infliximab, and they're finally doing well 2 or 3 years later, where the risk of stopping the TNFs means that you have a relatively reasonable chance of not being able to successfully reuse that therapy after cessation. So depends on the patient, depends on the drug, and if it's working, generally we encourage patients to stay on the therapy that's been working for them.
Ashwin?
Yeah, so I very much agree with all that, but I would always take a step back. I think it is very important. Most patients have a lot of difficulty, very understandably, with the thought of being on a treatment lifelong. So I am very clear with the patient that what we're starting on may not necessarily be lifelong therapy, that there may be a point where we can decide together as a group that we are going to give a trial of medication. So it's, I think, very important for patients to have that door open and to work with you in deciding the safest and most informed way to do that. In terms of completely stopping treatment, It depends on a lot of different things. As Lauren said, it depends on their history. If they've been historically very, very hard to get under control, then I would be very reluctant to stop it. If they have very few options to transition to, and I'm worried that they would form antibodies to what they're on currently, that's also a circumstance I would be very, very reluctant to stop it. If somebody is on their first biologic and has been in remission for 10 years with absolutely like no symptoms, not needed steroids, and is strongly motivated to stop treatment, I would be open to that possibility. I tell patients, once you stop treatment, we don't know necessarily when you'll flare, how bad that flare will be, and how quickly we can get you back into control. And so you have to be at a point in your life where all that uncertainty is acceptable to you. And if it is acceptable to them, and they've been in remission for at least 5 years, and they have a colonoscopy that is entirely normal, and MR or CT or intestinal ultrasound that is normal, and this is their first biologic, maybe their second, I would be open to saying, okay, we can monitor you closely off treatment. Again, very reluctantly. So I almost never bring up de-escalation myself. But for some patients, I think you have to work with them in doing it safely. And then I would monitor with the calprotectin every 3 months, do a colonoscopy 6 to 12 months after they come off, and continue to monitor them intensely. The last thing I want is for people to stop follow up and show up with a complication in 2 or 3 years. So that's why I think it's very important to have an engaged discussion with the patient. Definitely would not stop if they're moving to a different city, starting college, considering pregnancy. All these are conditions where you absolutely want 100% tight control, and I would not stop at that.
Great, thank you. Right, so Ashwin, so if you do rescue therapy with infliximab at 10 milligrams per kilogram, is it beneficial to redose at 5 mg per kg versus 10 mg per kg if symptoms not responding in a few days?
Yeah, in the acute severe UC setting, I've almost always now use only 10 milligrams per kilo. I can't remember when was the last time I gave somebody 5. And that's primarily I ask myself, if I've given 5, I'm always second guessing myself in a couple of days. I should have given 10. I have never looked back and said, oh my God, I gave this guy 10 when he could have done 5. So in the hospital setting, I would always use 10. And then as a maintenance, we don't know. I would add maybe 2 or 3 months, I would check their levels and see if they can potentially come down to 5 once their inflammation is under control and perhaps their fecal losses are less. But in sort of the acute setting, till I've gotten somebody into full remission, I would not de-escalate. In that setting, I would stay at the 10.
Okay, great. So Lauren, a couple of questions about the management of biologics around the time of delivery. Do you delay or do you just continue with a regular schedule? And a related question about, do you hold before scheduled delivery of biologics?
Yes, it's a great question. This is another one where, sort of our practice standard has changed a lot in the last, 3 to 5 years. We used to do things like modulating dosing, and we understand that the biologics really don't cross the placenta until the 3rd trimester. And so we were doing crazy gymnastics to try to avoid dosing during the 3rd trimester if possible, because then the baby wouldn't get any exposure to. We don't do that anymore because we understand that then, except in rare circumstances where a patient is on Q8 dosing, and even in that case, we unless it's really strongly patient preference, we continue patients on their regular scheduled therapy through the course of pregnancy. And I'm very encouraging of my patients also being dosed within the first couple of days after delivery. We have issues, of course, in terms of whether hospitals want us to do inpatient administration, but certainly that's my preference, just because there's risk for flare after delivery as well. And so it's not just the risk of delaying during pregnancy. It's actually that, you're overwhelmed, you have a newborn, you're up every 2 to 3 hours, you forgot to go to your infliximab infusion 1 week postpartum, and now you have an hospitalized mother and an infant, 3-4 weeks after delivery. That's not good. So we generally will keep patients on their regularly scheduled programming and encourage them to continue to be really vigilant about getting their medication on time postpartum as well. There was a nice study that was done that looked at sort of post C-section complications and whether there were any increased risk of infection, et cetera, depending on when biologic was dosed, and there's absolutely no correlation at all. So we don't think it really changes delivery outcomes, even if patients require C-section.
Great. Ashwin, there's a question about lymphoma risk, and is it seen only in biologics within immunomodulators?
So the risk of lymphoma is greatest in people on combination immunomodulator plus an anti-TNF. It is second highest in those with an immunomodulator. There is a slight increase in those on TNF alone. If you look, there was a large French study that looked at TNF monotherapy showing that there is a measurable increase in lymphoma risk. But again, we're talking about, with lymphoma risk, very important to have the absolute risk in mind. Like the numbers I quote people are, it's about 2 in 10,000 if you're not on anything. Maybe it's about 3 in 10,000 if you're on TNF alone. It's closer to like 4 or 5 in 10,000 with azathioprine alone. And on combination, it's probably closer to 7 or 8 in 10,000. So those are the numbers I generally quote.
Okay. And there's a question about here, use of JAK inhibitors in those who are older than 50 who do have cardiovascular risk factors. And in what IBD patients with cardiovascular risk factors should you avoid JAK inhibitors?
Yeah, so this is a long and complicated question. And it sort of stems from the oral surveillance trial, which showed that in people over the age of 60 with rheumatoid arthritis, tofacitinib was associated with a higher risk of cardiovascular adverse events and cancer than people on anti-TNF treatment, right? So that was the population where the FDA black box and restriction on use comes from. It's never been shown when used in IBD, never been shown in those younger than 60, never been shown in those without cardiovascular risk factors. So everything comes down to what the alternatives are. I would feel comfortable using upadacitinib in people over the age of 60. It would give me pause if they've had prior cancers or if they have multiple cardiovascular events. We talked about sort of episodic use before. This would be a circumstance in somebody with bad cardiovascular disease, but also bad IBD that I would consider using a JAK inhibitor sort of short term and then transition them to a safer biologic long term if there's the possibility.
Okay, and one other one here that rose to the top here is there any advantage of starting dual therapy when using non-TNF inhibitors for induction in newly diagnosed patients, specifically to reduce the risk of antibody formation?
No. So the rate of antibody formation with ustekinumab, risankizumab, vedo is of the order of 1 or 2% compared to about 20% with infliximab and adalimumab. So currently, the guidelines do not recommend routine use of combination therapy with some of these agents. In a highly refractory patient, I would consider using it. But in a newly diagnosed patient who's never been on a biologic before, I would use them as monotherapy.
Okay, great. We've got a couple minutes left. So, Lauren, can you give an example of a typical dose and duration of steroids that you'd give to a pregnant patient with an IBD flare? I mean, is it just what you'd use in someone who's non-pregnant, or do you try to make any accommodations in a pregnant patient?
Yeah, I mean, I think we're always trying to keep patients on the lowest dose of steroid for the shortest period of time. That's true no matter whether they're pregnant or not pregnant, but certainly during pregnancy, we try not to let them hang out on steroids for months. It's a little bit tricky to answer that question because so much of steroid tapering is an art and not a science, and it's dependent on the patient's response to treatment. But, you might think about doing, 2 weeks at 40 milligrams and then cutting down by 10 milligrams per kilogram every 5 days or so. But again, it's highly dependent on what's happening and also what else you're doing to try to treat the flare. So are you thinking about, this is a patient who's been on mesalamine monotherapy and is now having a significant flare in the middle of pregnancy? Where in their pregnancy are they? Are you starting a heavy duty biologic therapy at the same time as you're starting the steroids, where your intention is that the biologic is really going to hold the patient rather than the steroids alone? So it depends on the clinical context. But again, it wouldn't be a dramatically different steroid regimen than in any other patient. I always try to use the lowest dose for the shortest period.
Okay, great. Ashwin, when do you decide a patient with stricturing or fistulizing Crohn's at diagnosis is not responding to medical therapy?
Yeah, I mean, so that's a very complicated question, right? Everything depends. Everything I feel in IBD is relative. So I'm very clear with the patient that nothing is absolute. If somebody, let's sort of separate it out. For fistulizing disease, important things, make sure there is no residual fluid collection, right? Sometimes there are tracts and abscesses that are not drained that interfere with healing. So work closely with your surgeon, make sure that there's no residual perianal sepsis. Studies have generally shown that biologic therapy plus Ceton works better than biologic therapy alone. So I would get that done. We also know that for fistulae, the time to response is much greater than for luminal disease. So I would look for reduction in drainage by around 6 to 12 months, as opposed to resolution of like luminal symptoms, which we look at closer to 3 months. And then so that would be the time point of assessment. And if somebody's not responding, we know that there's not great surgical interventions for fistulae. So you would work on optimizing your medical therapy. There's not sort of a clear set in stone. For strictures, it's a different story because there are clear, definitive surgical interventions that are possible, particularly in people with isolated ileal strictures. And so there was this very sort of controversial study that came out just last year or the year before from Denmark, showing that a lot of people did actually very well with an early surgical resection for Crohn's rather than going on medical therapy. Again, that was sort of controversial and limited in a lot of different ways. But in somebody, let's say, they've not been able to come off prednisone in 2 months after diagnosis or 3 months, despite starting medical therapy, and are still restricting their diet, not gaining weight, and have an isolated ileal stricture that can resolve with a limited ileocecal resection done laparoscopically, I would absolutely consider surgery in that setting. I'd be worried about sort of prolonged dragging out on steroids without a resolution when there's a clear surgical intervention possible.
Great. That's terrific. Well, we've reached the end of actually went over our session, which is great, but I want to thank Dr. Rabinowitz and Dr. Ananthakrishnan for really a terrific Q&A session. I will ask them if they have time that, in the questions on the Slido, if there's some that you can answer quickly just by texting back, you can actually just do that right now. I'm sorry we didn't have time to discuss it in the forum with everyone in person. But thank you all very much. And so we will go to a break and we'll see you back here at in 20 minutes at 10:50.